All right, so that was a really nice summary, you two. It looks like for patients with BRAF mutations, you can give BRAF inhibitors or a combination of BRAF plus MEK inhibitors. And if they don't have a BRAF mutation and they have an NRAS mutation, we're starting to get some hints of maybe MEK and CDK4 combination therapies are helpful. But the challenge has been a lot of these therapies are temporary. With the targeted agents, they're temporary. And we're getting a lot of questions from the audience talking about second line and third line. What do you do if the BRAF inhibitor stops working over about 7 months? What then, and what's the salvage therapies?
So in terms of target therapies, there's some lack of data. What's the next second line treatment for these patients? So that's why the research involving the rational combinations of the different agents that blocking different pathways is very important. And they're also depending on how we can see, depending on the epigenetic changes at the time of resistance, be important to know so you can select the right combination. So I suspect within the next few years, we'll probably have some more idea which genetic changes at the time of resistance can be combined with a certain agent. And even better yet, maybe, possibly even upfront, can we just combine with triple combinations to make it even better? That's one question.
I think one of the lessons we've learned is the question of when patients have progressed on a BRAF inhibitor, is the right strategy to switch them to a different treatment or to continue the BRAF inhibitor and add things to it. As Dr. Kim described, for patients who progressed on BRAF inhibitor, our evidence is that the majority of patients have changes that reactivate the MAP kinase pathway. Now, despite that, if you then switch them from BRAF inhibitor to MEK inhibitor alone, or at least the trametinib, none of the patients responded. In the data that he showed, the only patients who responded were patients who had stopped the BRAF inhibitor because of toxicity. When we use the BRAF inhibitor in combination with the MEK inhibitor after patients have progressed, the response rate is about 15 to 20%. This is clearly not as good as what we see when you use that combination up front, but it's better than the MEK inhibitor alone. And so it's our first data to really suggest when patients progress on the BRAF inhibitor that there's a rationale to continue the BRAF inhibitor and add to it. I think the other thing is that Dr. Kim actually also presented data at ASCO a few years ago. In patients who progressed on BRAF inhibitor, some patients were actually continued on the BRAF inhibitor even though there was evidence of disease progression, and there appeared to be clinical benefit in those patients. And so I think one of our questions moving forward is not only, again, what is it that you actually give them after they've combined on BRAF inhibitor, but should you really switch them or should you continue the BRAF inhibitor and just be adding to it as we've done with other molecular targets like HER2 new amplifications?
And there are other alternatives. In fact, we have an interesting question from the audience that says, well, if we know that the BRAF inhibitor may work only temporarily, do you ever stop those at about 3 or 6 months and then start immunotherapy instead? And if you do, what's the course of action? If it works, fine, you continue, but if it doesn't work, then what do you do?
That's a good question, especially a patient with aggressive disease. We can hold treatment, we can actually hold tumor progression with the BRAF inhibitor-based treatment. And once tumor becomes small, the question is, can you start ipilimumab instead, or maybe interleukin-2 treatment in the future instead? That's a good strategy, but as of yet, in terms of durability of the approach, it has not been validated yet. So sometimes you can try that, but without any good evidence at this point.
I think one of the things that's probably good to talk about is what do we know about what happens when you combine BRAF inhibitors with immunotherapy. So as many people know, the first trial that was done combined the BRAF inhibitor vemurafenib with the immunotherapy agent ipilimumab. And this treatment actually was stopped very early because of evidence of toxicity, particularly abnormal liver function tests in virtually all the patients treated with this combination. Actually raised the question of whether we could combine the targeted therapies with the immunotherapies. At ASCO this year, we had data from another phase 1 clinical trial in which patients with BRAF mutations were treated with ipilimumab and dabrafenib, and then half of the patients also went on to receive treatment with trametinib. What we observed was that patients treated with full-dose ipilimumab and dabrafenib actually tolerated that treatment quite well, suggesting that the toxicity that we had with ipilimumab and vemurafenib was a drug-specific issue as opposed to a class-specific issue. And so it raised the possibility that we will be able to combine these agents safely. However, treatment with ipi, dabrafenib, and trametinib was stopped due to toxicities, particularly early significant bowel toxicity, including perforations. And so at this point, that arm of the trial has actually been closed. And perhaps in the future, we'll learn more about the benefits of combining ipilimumab and dabrafenib based on the results of this study. I would say just an other thing that's probably relevant to this question is there's preclinical data to support the rationale for intermittent BRAF inhibition. Then in a study done by Darren Stewart and his colleagues, they showed that if they treated a BRAF mutant melanoma cell line in mice that had a BRAF mutation with a BRAF inhibitor, if they treated continuously, you would always develop resistance. However, if they treated the tumors until they had shrunken maximally and then stopped the treatment and waited until the tumors started growing again, they could effectively cycle this treatment on and off for a very prolonged period of time. And there have been reports of patients who developed resistance to BRAF inhibitors, stopped the treatment, went on to other therapies, but then resumed BRAF inhibition later and actually responded. So again, in addition to trying to identify which patient is right for which strategy, what types of combinatorial approaches, this idea of how do you sequence the therapies and how do you actually dose the therapies are also emerging areas of investigation at this point.
So it's a really exciting time for patients with metastatic melanoma. There are so many new agents, both targeted agents and immune agents. We can attack their tumors with many things in our toolbox. Now, there are many ways to sequence this, put one and then the other, combination therapies. We do have to look at toxicities. So with that in mind, and all of these tools now at our disposal, how do you approach the patient, Dr. Kim? When a patient comes into clinic, do you start with a targeted agent and then go to an immunotherapy if it doesn't work, or do you do vice versa, or do you start with a combination and just watch the toxicity? What's your approach?
Sure. There's still there's a lot of the controversy about this area. The good thing is we have a lot of the ammunition against melanoma at this point. So patient with the BRAF mutation comes into my clinic, and patient has very aggressive, fast-growing disease. Then I think priority is also looking at control disease, and it's temporarily. So in this patient, we can give patient comforts and palliations. Also, it's very important looking at the long-term durable response as well. So in those patients with the aggressive, fast-growing tumors, I would usually pick the one with the highest response rate, so we can just control disease initially, which is the combinations of the BRAF plus MEK inhibitor, which has response rate nearly 70–80%. So far, this current standard of interleukin-2, ipilimumab, is a low response rate. So that's my approach, is those patients I usually tend to go with target therapy combination first. Patient with slow-growing tumors, we have a small number of tumors, then we have time to actually work with ipilimumab, and hopefully going for a long-term durable response. So in those patients, I tend to offer the immunotherapy first. And in the future, near future, with the anti-PD-1 coming on board, if it was approved, then it could be a whole game changer at the point. Well, depending on what response rate, duration of response can be very important to know to make decisions.
So it's certainly an exciting time and a very hopeful time for our patients. So in summary, your approach is that if it's an aggressive tumor, you'd start with a targeted therapy if the mutation matched.
Correct.
And if it's a slower growing tumor, you then would try the immunotherapy because of the potential of durable response.
Absolutely.
Makes a lot of sense, and maybe hopefully in the future, in the near future, we'll be able to have biomarkers to decide which one to start with first, and maybe combinations so that everyone will respond, or at least a larger number of people will respond durably.
I think it also just reinforces the point that although we've made a lot of progress, there's a lot of work still to do, and why we still think clinical trials are a good option for many of our patients, because we haven't figured out the perfect therapy for every patient yet. But again, we're very excited and optimistic about the progress that's being made.